Hi everyone, Bryan Lewis here with KidneyCAN. It's my pleasure to welcome you back to another joint edition of the National Kidney Foundation and KidneyCAN's NKF Live series. And today we're going to be discussing the topic of oncology pharmacy, or pharmacists who care for cancer patients. So my guests today include Dr. Syed Arafath. And Dr. Arafath, thank you for joining us. He's here today from New York Presbyterian Weill Cornell Medical Center. And he's an oncology clinical pharmacy manager who deals with the medications for kidney cancer patients. So thank you for joining us.
Thank you. Thank you, Bryan.
Great, great. Also with us today is Meryl Uranga. Many of you might know Meryl. She's a patient advocate from Georgia. She's also a recent grandmother. You got to catch up on that. And she's been on immunotherapy treatment for the past 6+ years. So she's going to be joining us with a lot of insights into this important topic. So here, let's get started. Dr. Arafath, tell us what exactly is an oncology pharmacist?
First of all, I'm glad to be here. Thank you, Bryan. So oncology pharmacists are pharmacists who are specialized in treating cancer patients. So there are different types of oncology pharmacists. Some of them have residency training in the field of oncology. Some of them have extensive experience through working. When you go get your chemotherapy in the infusion center, there are pharmacists in the pharmacy who prepare your chemotherapy to make sure everything is done properly, make sure your labs are okay, the drugs are mixed properly so you get the right medication. And there are other types of oncology pharmacists who are clinical pharmacists like myself who has residency training. So I mostly do clinical work. I work with the oncologists, with the nursing staff, with dietitian to make sure patients are getting right medication. So when we see a patient for the first time, we discuss as a team with the oncologist, with the dietitian, with the nursing, what medication should we give it to the patient. So I contribute my knowledge as a pharmacist and as a drug expert to the provider. Hey, probably we should put this patient on this medication based on the safety and efficacy data.
Let me just ask you real quickly. So when you're doing that, did you have special training in kidney cancer or kidney disease?
I do have training in oncology overall, where I did see kidney cancer patient. Yes, I do have training. Yeah.
Okay. We'll come back to that because I'm interested in hearing more about the training that goes involved.
Right.
So Meryl, give us your experience. You were diagnosed, you had a time that they were just watching and waiting.
That's right.
And then later on you were told you needed to go on to some therapy. So let's hear a little bit about it.
That's right. I was initially diagnosed and able to receive local treatment, which was surgery. In my case, I had a nephrectomy and a lobectomy. And then I was also receiving targeted therapy to the brain, radiation therapy to the brain. And after those treatments, I was essentially no visible evidence of cancer for about 18 to 19 months. After that, there was some progression, and it was decided between my care team, that it was time for me to start on a systemic therapy. And at that time, I started on a double immunotherapy combination, which was, in my case, pretty effective and also brutal in a lot of ways.
We're going to talk about that.
Yeah.
Dr. Arafath, so we're throwing a lot of big words here
Right.
for people who might not be familiar with some of the terms. So immunotherapy, and then there's some for kidney cancer patients, TKIs.
Correct.
And that's what Meryl's on. So let's hear a little bit about each of those.
Right. So cancer cells are very smart. When they get into your body, they try to hide from your immune system. Right? Our immune system always tries to fight against foreign particles, and cancers are foreign body. So what happened, these cancer cells are hide from our immune system, and there is a drug, it's called immunotherapy. That's the class of the drug. So when we give patient this immunotherapy, it kind of activate your immune system, so our immune system can identify those cancers and kill them. So that's how this drug works. And there is other class of drug is called tyrosine kinase inhibitors, or TKI. What it does, it cut the blood supply and the nutrients to the cancer cells. So the cancer cells cannot get nutrients from our body, and then they die eventually.
Okay. So Meryl, you're on an immunotherapy and a TKI.
Right.
So tell us a little bit about that. Sounds like you were actively involved in your care, and then you were told by your oncologist team it's time to move to therapy. Tell us a little bit about that time period. Were you aware of what was going to be happening? And
I was. I don't think, in retrospect, I was aware as I am now. But I did seek a second opinion with a specialist. I flew to Texas for that from Georgia. We all worked together with my, local oncology team and decided that it was time, and decided on the double immunotherapy treatment, which eventually there are two drugs. One of them is short term, the other was continued after that. But I did have an interruption with an adverse event taking place that caused me a permanent adrenal insufficiency, not very uncommon at all with this combination, and eventually moved on to the combination drug therapy, which is the TKI and immunotherapy, which I'm still on today, and it'll be 5 years soon.
I'm curious. I know that there are a lot of combinations out there for kidney cancer patients right now. Did you have choices, or were you and your team pretty much dialed in on this was?
No, absolutely choices, and a lot of them were sort of given to me personally, in terms of what I was willing to risk, what I was willing to go for. There was a clinical trial that we looked at. There was a more conservative approach than the double immunotherapy, but I went for what I thought was the best chances, which also came with the higher risks, but the best chances of a remission of sorts or a complete response kind of situation.
And so, Dr. Arafat, if I understand, Meryl, your immunotherapy is once every 3 weeks?
That's right.
And then your TKI is daily?
That's right.
So let's just hear, that's pretty common course of?
Correct. It depends on the stage of the cancer. Some patients can be on TKI monotherapy. Some patients can be on combo with TKI and immunotherapy. And depending on what type of TKI you pick, it could be 1 tablet every day, or 2 tablets, 1 tablet twice a day. Then some of the TKI, we give patients like a week off, and then we restart the cycle again. So depending on what drug we pick, it could have different schedule. Also, we keep that in mind when we pick the drug. Is this something going to be burdensome for the patient? If I pick a drug that's like you have to take 3 times a day with food, some patients may not take that because compliance is a big issue. And then we want to make sure patients are compliant with their medication so they can get the best response from the treatment.
Meryl, let's just talk in the weeds here. First day, you drive down. Someone drive you down to the infusion center, to the hospital. What happened?
I think I went by myself, and I was really scared. I think just the environment, the infusion center, being newish to cancer, it was a little intimidating, overwhelming feeling. And they watch you very closely for a reaction. Because
you had to give labs first, give blood?
Yeah, you always have to provide labs ahead of an infusion because there are certain factors that may prohibit getting the infusion. So that's all before the drugs are even ordered from the specialty pharmacy. They are checking your labs. When in the early days, they're checking you for reactions. Some people have reactions and have to be pre-medicated before an infusion. I was fortunate that did not happen, but my stress levels were really high. I remember even having to do deep breathing and calm down. Now it's routine. I can pretty much sleep through it.
So Dr. Arafat, that's common practice. You come in for an infusion, you have to get your blood work done ahead of time.
Correct. So we do get blood work to make sure all the organ functions are appropriate, because sometimes with this immunotherapy, they can affect in different organs, like your kidney number can go up, and that can have side effects, like this drug can cause a lot of different adverse effects. We check your liver function test, we check your thyroid function test. So we do a lot of different testing to make sure this drug is safe for you to get. What also we do sometimes, we ask the patient to get the labs the day before from their local lab center and send us the lab. So we can look at the labs the day before, make sure everything is okay, and then they can come and get the infusion.
Infusion right away, no
Right.
delays.
Correct.
So, Meryl, back to you. You finished your first day in infusion. You were there for an hour or two, went home,
2 or 3, yeah.
feeling okay.
Yeah.
Then the next day you have to take your pill for your TKI.
My very original treatment was just immunotherapy, so it was just getting infusions at that point.
Any side effects from those infusions?
Yeah, after my 3rd dose of, the brand name is Yervoy. It's that's the one you only get maximum 4 treatments of in this combination therapy. After the 3rd one, I started developing debilitating headaches. It was very difficult to pinpoint at first. I did a lot of research on my own, and we came up with, I did an MRI and found out that I had an adverse event called hypophysitis, which is a breakdown of the pituitary gland. As the doctor described earlier, the immunotherapy can set off an immune response in other organs besides attacking the cancer, and that's what happened to me, and it left me with a permanent adrenal insufficiency, which I have to treat on a daily basis for basically the rest of my life. But so that stopped those infusions. I never had that drug again. I had 3 out of 4 max, and had to be treated with high-dose steroids, and then was able to jump back on to the other immunotherapy drug after that.
So this sounds like a common practice. There's patients that are going on to different treatments, different therapies. You all are monitoring, the patient's monitoring, and then they come back and say, I've got this going on.
Right.
What do you all do behind the scenes when you hear about these side effects?
Right. We always tell the patient, we educate them as a pharmacist to make sure you report us back all the side effects that can happen. We usually give them a handout that tells them the major side effect that can happen from this drug. Also, there is a predictable timeline when we kind of expect this side effect can happen. So patient will have some mental idea, probably I am having this side effect from this drug. So once they report us back, we look at the side effect and see how severe is the side effect. Is it something we have to stop the drug or switch to something else, or is this something is manageable?
Well, I can imagine there's a long list of potential side
Right.
effects. Are there any, for kidney cancer patients, are there any common ones that sort of run fairly regularly with folks, or?
Yeah, so from immunotherapy, there are 4 or 5 different side effects that we usually tell the patient. Those are more common. It can affect your lung, that can cause pneumonitis. It can affect your adrenal gland, like Meryl, what happened to her. It can affect your kidney. It can affect your liver. It can affect your thyroid gland. So we do labs for this reason to make sure all these organs are okay before we give this drug.
And Meryl, were you keeping track of this at home? Did you have some way of?
I was, because it was drilled into my head very strongly that you have to be very alert on immunotherapy, especially this combination, for anything out of the ordinary to report it. And so I was very hyper vigilant about that because I knew I couldn't slough off anything. It's just really important to check it out because of the commonality of those kind of adverse events happening. When I talk to patients now, I really also like to drive that point home that it's really important, be vigilant, report anything out of the ordinary because you just never know with these, and the sooner you treat them, the better, and you can kind of carry on with your treatment after that. It's just a really critical point that people need to understand when they're taking these drugs.
Got it. So I think we're throwing around terms loosely here, side effects. Side effects can range from very mild to very debilitating. So there's also a term adverse effects. So how do you gauge a side effect being, not so important to very, very important?
Yeah, it all depends on the drug that you are getting. Some of the drugs can have some of the side effects that can alter like your life that can have like debilitating effect down the line. For example, if you have the same side effect that Meryl had, like it affected her pituitary gland, right? And that kind of break down the normal circadian rhythm of your body. So that's a really important side effect to manage. And sometimes we have side effect like diarrhea, like once a day maybe. That's something like more manageable. So what we do, we treat the patient based on the side effect. And then we observe the patient to see if the side effect getting worse, right, down the line. If that happens, then we have to take action, right? We have to either discontinue the drug or give them some other medication to prevent that side effect, and then we go from there. So it all depends on the patient, the situation, and the drug.
So Meryl, I'm going to come back to you. Did you have to take a break? Were some of the side effects really tough?
Yeah, and on that last point, it's just the adverse event. I use that term when speaking of something that, you know, was like life-changing, like we said, where, you know, it needed treatment, it needed a high dose.
An adverse event.
Yes, and
Okay.
then the side effects is more of the kind of everyday effects of the drugs, mainly the TKI drugs that have to be managed. They do have a scale and a spectrum. They ebb and flow. Sometimes they're very difficult to manage, and they require more medications like blood pressure, like the diarrhea that he mentioned and stuff like that. Thyroid, it's very, very common, thyroid breakdown. And those are part of just kind of like everyday life on these medications, whereas the adverse event really is like potentially life-threatening quite a bit, especially.
And something that either you made a note to let the doctors know or the nurses know.
Yes.
Okay, and this theme here is quality of life when you're on this therapy, these therapies. Did your life change dramatically? Did it ebb and flow? Did you get to do things that you were normally doing? Did things change a lot?
I have been all over the place with it. Like, I really want to drive that point home that it comes and goes. I've had normal blood pressure. I've had scary blood pressure. I've had, terrible gastrointestinal issues. I've had, hardly any. And it just has to be managed, monitored, and treated. And it has not affected my quality of life very much, but I can't say it hasn't at all, because there are times that, you have to think ahead, you have to be prepared, unlike, when you're just kind of carefree living.
Yeah.
But it doesn't stop me from living my life, enjoying traveling, things that, I really want to do. So there is hope for that, but you have to be on top of it.
Eventually.
You really do.
Yeah.
Like most of life.
Yes.
So Dr. Arafat, some folks out there might not have the luxury of having an oncology pharmacist at their hospital. Maybe they're in a rural area or whatever. Any advice to them or any recommendations to them if there's not someone who's dedicated like you are?
Yeah, so there are always pharmacists there who may not have a specialized knowledge in oncology, but they are pharmacists, they are drug expert. So I would recommend this patient, if they have question about their medication, ask your provider, ask your nurse, hey, I want to talk to a pharmacist. So they can talk to a pharmacist to go over their medication, and that can be done in any hospital. Also, when you go pick up your medication from your outpatient pharmacy, from your specialty pharmacy, there are pharmacists there who are specialized in oncology because they are dispensing your oral chemotherapy. Always ask this pharmacist, hey, is there any drug-drug interaction? Like, how should I take this drug? Should I take with food or without food? Any side effect that I should monitor? So there are always, we are very accessible everywhere. So I always ask patients, look for a pharmacist and ask them question.
So help me to understand, state by state pharmacists are regulated and licensed, and then to become an oncology pharmacist, you had to go a little bit further.
Right. So what I did, I have board certification. It's called the BCOB, Board Certified Oncology Pharmacist. It's an exam that I take, and then I become oncology like board certified oncology pharmacist. Also, some pharmacists who does additional training, they do residency training for a year or 2 years to be specialized in oncology. And they can practice in different states. So we have one license from the State Board of Pharmacy to practice in that state. And on top of that, we get a specialized like training in oncology where we can practice anywhere in the country.
And like other healthcare practitioners, you have to keep going back to school or go?
No, we have to take something called continuing education or CE credit. So we have to get those CE credit, certain number of credit to make sure we are on top of that. Also, when you do like clinical practice, you go see the patient, talk to the patient, you have to know your stuff because you have to discuss that with the patient and with your team, with the oncologist. So we constantly go back to the guideline and see like what's new out there. Yeah, we are on top of that.
The landscape seems to be changing
Right.
on a regular basis.
Right.
So let's shift gears a little bit to finances. And so, Meryl, I know that you were thrown into the deep end with getting these two therapies. Did you encounter any challenges with getting them covered?
This is a topic I'm pretty passionate about because for whatever reason that as a layperson I'm not sure of, that there are tremendous burdens of financial copayment issues with the TKI oral drugs in particular. The immunotherapy is usually covered well by insurance because it's under a different umbrella and it's done in the hospital setting and just the drug itself is usually covered. But with the TKIs, it is a huge burden to people regardless of your state of finances to pay a $1,000 to $2,000 copayment every month for these drugs. So I've spent a lot of time researching and utilizing myself resources that are out there that you may not know about at first. I surely didn't. I had no idea. And there are foundations and there are organizations that specialize in getting you to the right place for this a copayment assistant. And if all else fails, the pharmaceutical companies also have in-house programs. They encourage you to go through the copay assistant programs first. But if those run out or are limited in resource, then you can also go to the pharmaceutical company itself that manufactures your particular drug and request help because it is, I mean, there's enough financial toxicity as it is to cancer patients. There's so much of that, and in many regards, some patients just aren't capable of managing all of that. It's a huge, it can be a huge burden. So I would just like to put out there, contact me if you want more information on these resources. They are available to everyone. Most of them are not income dependent. They are just, because these are huge burdens. Like I said, $1,000 to $2,000 a month in co-payments for one prescription could take anybody down pretty quickly.
Right. And so I think later on we'll be sharing those resources with everybody, and we'll
right.
also share some email addresses.
Yes.
I want to go to some of the questions that seem to be coming through here. I'm going to sort of butcher this one, but I'm going to ask you, Dr. Arafath. So what do you do? Meryl had mentioned that she was scared earlier on when she was getting started. What do you do with folks that are unwilling to tell you of their side effects?
Right. So when we counsel the patient before they start any new medication, we usually give them a diary, a handout, and we ask them, hey, write down all the side effects that you may have from this medication or anything like you're not sure, is it from the drug or from something else? Write it down, tell us, bring it to us next time you see us. So that's how we know like what kind of side effect you have. Also reassure the patient, hey, this is not end of the world. There are other treatments out there. If you have some side effect that's is debilitating, that's like affecting your quality of life, we may have to switch to something else, right? And these days, there are so many different treatment options available. I tell the patient, like, there are other treatments out there that might be better for you. We reassure the patient, we calm them down, make sure they understand the importance of telling us all the side effects. Also, we make sure they're compliant. I usually call my patient after they first start any new medication to make sure they are taking it properly, to make sure they don't have any side effect. And they know like we always are there. We always are there to take care of them. Like we work for their interest, not against their interest. So they trust us.
And are patients sometimes worried that if they are honest with their doctor, they might be told they can't take the treatment anymore?
Yeah, I was going to recommend a way to get them to take, to report side effects is to kind of scare them a little bit and, just let them know how critical, because I think I mentioned earlier that some of these actually are life-threatening side effects, especially with immunotherapy. And so if a patient is educated properly about that, there should not be any fear in making sure that, that you can be treated, be handled, the earlier the better kind of thing, and, carry on with your treatment.
I also want to add one thing. I always ask patient to make sure you ask this question to your healthcare provider, to your pharmacist or to your physician, to make sure you get the right information. Because if you go online, there are a lot of misinformation out there and a lot of resources out there that don't tell you the right information that might be misleading and they may not be appropriate for your kind of condition. So I usually ask all of my patients, if you have any question, feel free to email me, call me. We are always here, or ask your oncologist. We'll get back to you as soon as possible.
Okay. And so Meryl, back with your therapy, you're doing the infusions every 3 weeks and you're taking your medicine ongoing. If the side effects ever got bad, did you ever have to take a break, or can you take a break?
Absolutely, yes. With the TKI drug that I'm on, breaks are not a part of the way that it's the dosage is prescribed, but some of them are. They are actually prescribed to take for a number of days, take a break for a number of days. With mine, it's discretion. It's what's going on, and I can just go to my team. In fact, my oncologist kind of trusts me to say, we need a break, we need a reset, and so I can do that pretty regularly if needed. And I will say that after the number of years that I've been on this treatment, that they're needed. This is a drug that has a significant impact on quality of life and your potential health in other areas. And so sometimes you just need a break from it mentally and physically to carry on with a long-term treatment like that.
Sure. Dr. Arafat, if someone does take a break, how does that impact their overall, success on the therapy?
Yeah, so it depends at what point we are giving them the break. At the beginning, I usually ask the patient to take it to have the drug enough in their system. We call that term steady state. So we make sure they have enough drug in their system so that the drug can work properly. But in the long term, you're taking your medication for 1 year and 2 years. You are well controlled with your treatment. You don't have much side effect. We are not worried about the cancer coming back. At that point, as Meryl mentioned, we can give them some break. It's a clinical decision. We discuss with the oncologist. We look at the patient, where they are right now, and then we decide if this is something can be done.
Okay, so taking a break is not out of the question. So for folks, okay, great. Well, we're getting tight on time here. So Meryl, I want to do the Monday morning quarterback question. So if you knew now, or I should say, if you knew all the things that you know now back then, anything different changed?
I think the main thing is I would have been much calmer about not being on medication. When I was initially on active surveillance, I was stressed that we weren't doing enough, that it was not going to keep the cancer away and everything. But I should have enjoyed that period much more than I did, because once you start on this treatment, it is a real roller coaster and a juggling act of managing quality of life with side effects and efficacy of your treatment. You have to have all of those in play in order to stay on a drug like that long term. And so I think I would have enjoyed my time away from it, or not on it yet, a little bit more. And I would have been probably a little bit more prepared for the juggling act part. And realizing that it comes and goes. Just because you don't have one side effect today doesn't mean you're going to not have it tomorrow. And vice versa. You could have one for a long time and it ease up and go away. So it's just, being an informed, educated, aware patient is critical when you're on these treatments.
I'll put a shameless plug in here for Smart Patients. That's one of the forums that you probably are participating in to get a lot of information. Are there other resources that you can think of? I know we're going to share some later. Dr. Arafath, any resources that you all give out to folks?
Yeah, I do. There is a really good resources on NCCN website for patient. They talk about like different types of cancer from start to end. They talk about like how we diagnose this patient, what kind of treatment we usually give. And the most important part, they talk in patient-friendly language. They do not use like hard language that's hard for patient to understand. So I always ask the patient, hey, go to the NCCN guideline, and there are a lot of patient resources out there. Also, when I talk to the patient, I make patient education handout that's patient-friendly. So I give it to them, and I go over the whole handout with them that talks about how this drug works, what would be your schedule, some of the side effects, when should you call the provider, and what to look out for, like what to monitor. So I think, as Meryl mentioned, education is very, very important. It's the power. And sometimes like patient like want to know like what they're getting. And that's like very important.
So last comments, I got to wrap up here. So any last minute advice to those
I just want to piggyback off of that last thought of like, yes, Smart Patients is amazing because you're talking to people like-minded that are very interested in knowing what's going on, educating themselves, and more importantly, have real-world experience, either as a patient or a caregiver, that can share their experiences. And an additional shameless plug, our KidneyCAN Patient Resource Center is an amazing resource to find. We have lots of YouTube videos. We have all kinds of resources for patients and caregivers to tap into to understand more on this topic and so many others.
Great. Thanks, Meryl. Dr. Arafath, any last minute nuggets for takeaways for folks listening?
I would ask patient, always ask your pharmacist the drug that you're taking. Sometimes there are interaction with these TKIs or with the immunotherapy. So always ask your pharmacist to go over this drug to make sure there is no interaction. And we are like readily accessible everywhere. So if you have any question, you can email me or you can call your local pharmacist. They will be
Even
happy
for
to.
supplements too, right? And stuff like that. You have to be very careful about that.
Yeah.
Okay.
Call us anytime, and we are happy
Open
to.
door policy.
Yeah.
Love it. Love it. All right. Well, unfortunately, we've run out of time. And in case we didn't get around to answering your question today, please check back on the National Kidney Foundation and KidneyCAN's Facebook pages, and we'll be posting the answers throughout the coming days. I'd like to thank all of our sponsors for their generous support in making this program possible. And I'd especially like to thank Meryl and Dr. Arafath for joining us today and helping to make sense of what I know can be a really difficult subject out there for many people. So thank you both. Appreciate it.
Thank you.
And on behalf of the National Kidney Foundation and KidneyCAN, I'd like to wish you all good health.